So good evening, doctors. I'm Dr. Prachi from Shield Healthcare, and I'm very happy to start with yet another episode of Task. So under the aegis of AGOG, that is Academy of Global Obstetric and Gynecology, and Shield Connect, we are beginning with this task series. So I would like to play the video. So these are the trending series. So whatever the trending topics are there, the hot topics are there that we discuss, and we are beginning with yet another episode. So we are very privileged to have Dr. Niranjan Chavan with us, who is supporting us with this series. Sir is Unit Chief, LTMMC and LTMGH SAN Hospital. Joint Treasurer FOGSI till 2024, Vice President MOGS till 2022. Member Oncology Committee SAFOG till 2022. Recipient of Maharashtra Healthcare Excellence Award in 2021. And also received MOGS Teachers Day Felicitation Award recently. Sir has many publications in international and national journals, and he was guest speaker at various platforms. So with this, may I request Sir to introduce our guest of honors and speakers. Thank you, Sir, and over to you.
Thank you, Dr. Prachi. Today is 13th of October when we are having the Trending Task series number 8, and it is my privilege and honor to welcome Dr. Chandrawati Madam. Dr. Chandrawati Madam is a Professor Emeritus at the King George Medical College, Lucknow. She is the Director of Krishna Medical Center, President of UP Chapter Obstetric and Gynae, past Vice President of FOGSI. She has got many awards from the central and the state government for her family planning work, and has received and published more than 50 papers in the national and international journals. She is also the research guide to more than 150 medical postgraduate students in the Department of Obstetric and Gynecology. The first time I met Madam was in 1999, where she was the main organizing person at the Lucknow AICOG. What we witnessed is the similar feat done by her and her juniors in 2019, where we saw again AICOG Lucknow being done. Madam is absolute gem of a person who is a guide to many teachers, and she has been always encouraging for members like us. Madam, we are very grateful to you that you have come today. We would request you to please encourage and guide us with your words of pearls of wisdom.
Thank you, Niranjan. It was a real pleasure when you talked to me and called me. I could never said no to it, because the love you and Komal have been showing, it has always been fantastic. I know you people are doing such great job and about this Academia Global Obstetric and Gynecology. I think I wasn't very aware of about this, but you are having this 8th series, and I think about in the past 7 series already you have done with important topics and with the journal also of this same club. Today's, when I saw the faculty and I saw the platform of guest of honors like Tushar and Haresh, it was really a pleasure to be here present on this platform. I know you people are doing tremendous hard work, doing your college job, doing all this extra work out of that. and also looking after the FOGSI's well-being. It is tremendous, and I think people should be given some sort of special medicine to have extra courage and energy to do all this work. I really wish you all a great success, and I will be listening to your topics because I'm very much interested in J B Sharma's topic and Haresh Atul's topic. So I'll be there all the time throughout your whole program today, and in future also, whenever there's a time, I would like to connect with you when it's possible. Wish you all the luck and success for this effort. Thank you.
Madam, we are not going to leave you just by.
I know. It's a pleasure to be with you.
Because,
Yeah.
you know, in the frame, all of you are eminent, you know, teachers. I think more than 40 years of experience, ranging from 40 to 35. And I think I'm the youngest of all.
Yeah.
So, Madam, I'm really grateful to all of you and you being there. I still remember that winter in Lucknow, the fog which was there at the Taj Hotel. And the first time I enjoyed the cuisine of North India and the amount of starters. And I still remember those chaat and the beautiful spread which was there in the food stall, and it was a winter time, and Komal and I really enjoyed, and I still remember that evening banquet night at Taj where the fog was there in the gardens. And Madam, those wonderful lovely memories you gave to us, that was 22 years back, and I will never forget. Of course, we had wonderful time at the AICUG 2019 also, where Lucknow was shining bright. And Madam, you are always an inspiration to us, to all of us who are there. Thank you for being there with us.
Thank you, Niranjan.
Now I call upon the rising star. I can say the sun, you know, arises from the east, from the land of Jagannath Puri. And he is also the professor and head of the department of the Sri Ramchandra Banch Medical College, which is Cuttack, which is nearby 20 kilometers from Bhubaneswar. It's a beautiful place. You have in there wonderful town known as Pipli. Please do visit it because it has hand-woven handicrafts, and you can take them back as souvenirs from the state of Orissa, Cuttack, the land of Konark and Jagannath Puri. Sir is a past vice president of FOGSI, chairperson of ICOG. He's been also the part of IAGE and IJOG as a peer reviewer, has received many awards, a gem of a person. And I remember when he was a vice president, I got the opportunity to give a lecture by the Pune Obstetric Gynec Society when Dr. Sanjeev Kurd was the president, and that's where I met and interacted with him. From there on, there has been no looking back. Since the time we met, we have shared a wonderful relationship, and sir is always a mentor and guide to everyone. Sir, I request you to please say a few words, and thank you for joining today.
Thank you, Niranjan. Really, it's a great time that during this pandemic, you have invited all of us, especially the old friends, Chandrawati, our teacher, as well as I call her always my elder sister, Haresh, you see JB from EMS, and Atul. So almost it's like an old friend sitting in one of the hotel in the round table. It seems like that. And Niranjan always makes, you see, academics from the fun. That is his, you see, gesture. Whenever he meets me, I always feel him as my younger brother. And always he tells, he comes out with academics from the fun. I always tell friendship like that, with the cup of tea in the hand and discussing about the academics. And you know, this type of things, whenever you start, this is the 8th series. I love it so much, the academics. And you see, you have selected such nice speaker like J B Sharma, like Atul. So really many people will be benefited, especially the practicing clinician, by coming together with the same topic. And for last 7 series, you are with this event AGOG. And AGOG, I think it will be definitely helpful for all of us and those who are practicing and postgraduate also. Niranjan, and I'm very happy that you have come over in such a big way to the platform of FOGSI. And I wish all the best, not only in the academics, but for the also FOGSI. You will be definitely contributing a lot in the future to the FOGSI. I hope, I mean, what I mean you can understand. Yeah. So with this, I think everybody will be benefited from this, and let it be continued in this way. All the best, Niranjan.
Sir, you have to be with us
Yeah.
for your expert comments and your experience in both the topics. Thank you so much for being there with us. Now I come to another professor from the land of Gujarat, Mahatma Gandhi, the father of the nation. He is from Ahmedabad, a very down-to-earth person. And whenever I have heard him, he speaks in between. He has got brain teasers, and he will make us quite attentive. Even our attention span, if it has got wavered or it has wavered in another direction, he will get us back to us. So thank you so much, Dr. Haresh Doshi, sir, for joining us. Sir is also the professor at the medical college. Can I have his slide, please? Dr. Prachi?
Sir, I have shared the slide.
Yeah.
Is it visible?
Can see.
Okay, sorry. Well, sir was our vice president in the year 2018-19. He has also been associated with other hospitals of Vadodara as an assistant professor and associate professor at BJ Medical at Ahmedabad. I can say he is an encyclopedia. He has written many books. And when I go to the operation theater, I find my residents in the operation theater getting big books. So when I ask them what is it, they find, they show me reluctantly, and there I find the name of Dr. Haresh Doshi. He has written books on obstetrics. He has written on gynecology. He has written books on monogram, and it's really amazing. That's how I came to know. And then further, he was also the vice president of Dr. Komal Chavan, and he has got more than 30 years of experience. Thank you, sir, for joining. I would request you to please share your pearls of wisdom.
I think sir muted.
Sir, please unmute, sir.
Thank you.
Yes,
Thank
sir.
you. Audible. Thank you, Dr. Niranjan, for your nice words. Basically, I am a passionate teacher. I want to teach everybody. You, GSPGs, and my faculty members also all these years. But what I see in you, you said you are the youngest. But now you have entered the FOGSI and looking to the right, all your academic activities, you stand above us. Now you are doing lots of activities, both of you and Komal, right? So many activities, and now you entered the FOGSI, long way to reach to the president of FOGSI. I wish you all the best. And my right, namaskar to Chandrawati madam. As you mentioned, I have been also there in 1999 and 2019. You are right. A nice faculty today, Dr. Tushar Kar, the great Dr. J B Sharma, and your own Atul Ganatra. Thank you very much.
Thank you so much. Thank you, sir, for joining us today. And we would require your expert comments in between. Thank you so much. Now, can I have the slide of Dr. J B Sharma, sir? J B Sharma, sir, I met in 2000. And he introduced his card. I still remember his email ID. It is JB Sharma 2000. Am I right, sir?
Yes, sir. Yes.
Yes, I met you in 2000 only. Probably after meeting you, you made that email ID. Or probably just it was a coincidence 2 days before. And we were having lunch. I think it was one of the AICUG conferences probably. And there I saw a tall, towering personality. And of course, 21 years have passed, sir, since then.
Yeah.
Still there as a faculty in All India Institute of Medical Sciences. In between, I had visited in 2014, sir, in Delhi, and where there was Tayapol Award. Again, I saw the amount of work which you have done as an editor of Indian Journal of Obstetric and Gynecology, and you were felicitated along with Dr. Arul Maran. And then I realized that this man is a man of passion, and you always share your expertise and the affection which you have with United Kingdom, where you have gone at many times in between and taken a lot of efforts to upgrade your knowledge and skill. And that is what you can see in an academician, always searching for knowledge, always getting training from one of the professor, that's Linda Cardozo. He is also editorial in chief of many journals, but presently he is holding the office of the Urogynecology Committee, and he has got various inventions. And I thought the best person today in the Indian subcontinent is none other than Professor Dr. J B Sharma, who can really speak. I know within 20-25 minutes, it will be very difficult for you to squeeze in SUI, because it is a topic which will take about 4 to 5 hours or probably a whole day to teach. What can I say, sir? You have done a nice synopsis of all those efforts which you have taken in urogynecology, and all we are waiting. There are more than 2,200 members who already logged in, and I'm sure they're going to enjoy this. And without much ado, I would just hand over the mic to you, sir. Welcome, and the floor is yours. Thank you, sir.
Thank you very much, Niranjan sir. As you said, you may be the youngest, but you are the brightest star, with permission of all my esteemed colleagues. And respected Chandrawati madam, Dr. Tushar Kar sir, Dr. Joshi sir. So it's a real pleasure, and Niranjan is like brother. And I mean, the minute I met you, I mean, I thought it just like, we were lost brothers and found somewhere. So, and I think both of us shared basically teaching the youngsters and, trying to inculcate the habit of reading and all. So thank you very much. So I think we start with the topic today. And as Dr. Niranjan already said, that stress urinary incontinence is an important topic. So I'll try to, do justice in 25 minutes. So can we start the sharing, Prachi?
Yes, sir, I'm sharing the slides.
Okay.
Yes.
So as sir said, so basically, I mean, urinary incontinence is an important problem, and it's a huge topic, but like we will restrict to stress urinary incontinence today. Overactive bladder syndrome we will discuss at some other time. So next slide, please. So this is how we will be discussing the topic. Next, please. Yeah. So grossly, I mean, all of us know that, we got bladder, 2 ureters coming into that. And then what I want to highlight is that 2 ureteric opening there, and then the internal sphincter, and then external urethral sphincter. So internal sphincter is not in our control, but external sphincter is. And this is the transitional epithelium of the uroepithelium, basically. So, and all of us are aware of the ureters. We are scared of ureters and bladder whenever we are doing gynae surgery. But let me tell you, bladder and ureter are friendly organs. And if we respect them, they will respect us. And even if rarely there may be injury to bladder, it's very forgiving organ. Our HOD urology always say that if you respect it, even if there is an injury like previous cesarean section sometimes, so if you repair it well, there is an adequate blood supply, and usually results are excellent. Next, please. Okay, so basically these are the sports of the urethra. This is important because that's how we can understand SUI. So extrinsic sport are levator ani, endopelvic fascia, arcus tendinous fascia pelvis, and then the intrinsic sport are striated and smooth muscles of the urethra, epithelial coaptation of the fold of urethra, tone of urethra, urethral elasticity, and congestion of some mucous venous plexus. This is important because extrinsic sport like levator ani, endopelvic fascia, arcus tendinous, they get torn during the childbirth trauma. So childbirth trauma, especially difficult delivery, forceps delivery, and all, they are the factors which can cause actually injury to levator ani, endopelvic fascia, sometimes twigs of pudendal nerve, and that causes basically injury. At that time, patient had delivery at 28 years of age, but she may not have SUI at that time. She may have it at 40 years of age, but though the seeds of trauma were at 28 years. So why it happens is the intrinsic sport. So at that time she was young, so there was good epithelial coaptation of the folds of urethra, good tone of urethra, urethral elasticity, and striated smooth muscle of the urethra. But as congestion of some mucous plexus also depends on estrogen. But as she advances her age, so because of lack of estrogen, all this will go down. So epithelial coaptation will become poorer, the mucosa become thinner and the submucous venous plexus become thinner. So in other words, basically that, now there is more spacious urethra and all, and then she can leak urine. So though the damage occurred during childbirth at the age of 28 years, but she may develop the symptoms at 40 years, 42 years. Sometimes they can develop symptom at that time also, but usually they happen later on. So that is the important concept of that. Next, please. Okay, but I won't recommend that we should do elective cesarean section for all. That's not recommended in India. This is the same thing, basically extending sport, hammock hypothesis, and increased intra-abdominal pressure. So normally what happens whenever there is raised intra-abdominal pressure, because proximal urethra is an intra-abdominal organ, so raised pressure is communicated to proximal urethra also. So intravesical pressure is always less than intraurethral pressure, because that pressure is communicated. But if there is childbirth trauma, then the proximal urethra gets displaced distally. So now raised intra-abdominal pressure is communicated to the bladder, but not to the urethra. So intravesical pressure becomes more than intraurethral pressure, and then patient leaks urine. And that is the concept of basically Burt's corpus suspension also, that we are bringing it back into the abdominal cavity, proximal urethra, and that is the success rate is there. Next, please. Okay. So yeah, so again, same thing basically. So, these are like detrusor muscle, urethral muscle, external sphincter, and we have actually sympathetic nervous system from T10 to L2 that we call inhibition of the detrusor muscle and stimulation of the urethral muscle. While parasympathetic S2 to 4, that will cause stimulation of detrusor muscle and inhibition of urethral muscle. So what I want to highlight, and then of course pudendal nerve S2 to 4 can help in external sphincter. So what I want to highlight that it's the parasympathetic nervous system which makes us to pass urine. So parasympathetic S2 to 4 is important. It helps us because it contracts the detrusor muscle and it will cause basically relaxation of the urethral muscle tone. While sympathetic, when at the time now I am delivering this lecture, at this time my sympathetic has to be stimulated so that I hold on to urine. That is the important concept. And somatic will take care of basically external sphincter. So even if my sympathetic parasympathetic fail, then somatic will control to some extent. Next, please. Okay, so the same thing basically we know that stabilization of detrusor pressure, intra-abdominal location of bladder neck, which I already highlighted, and the hammock hypothesis, intra-abdominal location of proximal urethra, urethral muscle tone, which we have already discussed, they make us continent. Next, please. Yeah. Okay, so what is urinary incontinence? So if this system, if this basically defensive system becomes obsolete because of some reason like childbirth trauma or poor estrogen or some other causes, then they'll develop urinary incontinence. So it's a condition of involuntary loss of urine on effort, physical exercise, coughing that is often bothersome to the patient and frequently, inhibits the quality of life. And any complaint of involuntary leakage of urine is urinary incontinence, but raised intra-abdominal pressure is stress urinary incontinence. Next, please. Okay, so these are the grades of incontinence as a whole. This includes urge incontinence also. Grade 0 means patient is continent. Grade 1 is mild, in other words, moderate. Grade 2 and less severe and more severe is grade 4. That means total incontinence, even without effort. Sometimes urine leak occurs. So today only I was seeing a patient. She said whenever I stand up, I just lose urine. So she was in grade 4. Next, please. Okay, yeah. So this is the epidemiology. We think actually we never had proper studies done from India. So we tried to do some studies, and overall, if you see from outside, almost 45% women will have some incontinence between 30 to 90 years of age, and almost 15% of adult women. And among SUI, among women's SUI, 77% have bothersome symptoms. So it does affect the quality of life. But unfortunately, many times patient may not come to the doctor. I mean, what happens if a patient has chest pain? She will immediately rush to the doctor. It can be MI. She has stroke. She rushes to the neurologist. If she has bleeding from any side, she thinks it can be cancer. But if she leaks urine, then she talks to someone, they say, well, it's a part of normal aging. So patient may not actually come to the hospital. So that is the thing which we need to change actually, which we need to tell our friends, that their mothers, their wives and all, so we can help them. And the patient may have symptoms like stress incontinence, raised intra-abdominal pressure, while urge incontinence, if she has to go, she has to go. So the two things are different. So we'll restrict mainly to SUI today. Next, please. And we try to do so as you can see in this case, as age advances, all types of incontinence including SUI increase. So I mean between 80 to 85 years of age, almost 30 to 40% patient will have some incontinence. Next, please. Okay, yeah. So we actually tried we did a study, I mean published it also, and it was almost 8 to 9% in daily clinics, but many patients did not come, and you had to ask a direct question from the patients. And then my this 8th semester student, actually you can also see it, Sena Agrawal, I'm giving her name also. Now she's an IAS officer and deputy commissioner in Punjab. Now she topped in IAS exam. So she did a study when she was a medical student, and I was surprised that she, I made a questionnaire for her, and we could find 19% in second trimester trimester, and almost 25% in third trimester were having SUI. Dr. Niranjan sir, I mean, and even I was surprised that because they didn't tell me. So when we asked them direct question, then only patient told about, I mean, that we have got SUI. But if you ask them, I mean, otherwise, like for bleeding, they will always tell us. If they have pain, they will tell us. But urinary leakage, they don't tell us unless you ask them direct question. Next, please. And yeah, so these are the risk factors basically. And as I said, single most important risk factor is pregnancy and vaginal delivery, caffeine, fluid intake, certain medication like diuretics, constipation, chronic cough. I mean, I'm seeing that, now I'm doing PV examination. Every third patient has got rectum loaded with fecolis, while 20 years back, I mean, I could hardly see any. So constipation is becoming a big problem in India also. Then conditions affecting mobility, medical conditions like diabetes, stroke, etc. The estrogen therapy, smoking, diet, depression, urinary tract infection, conflicting evidence regarding status. So this is important that when we are dealing a case with SUI or urgent incontinence or any incontinence for that matter, we need to take a detailed history. Many times I keep getting patients, they say, just sir, put tape in her. Our own professor of microbiology, she brought her mother, admitted her, brought a tape for me, and she said, sir, look at my mama cough. Mama coughed, and she was leaking urine. And then I checked, I carefully examined her and all did, and she was having stroke. She was having neurological problems. So putting a tape would have been a disaster. Another professor of senior consultant of gynae, she brought her mama again. She said, mama coughed and she leaked urine. When I palpated her, she had 800 ml bladder, full bladder. So I said, she already has obstructive element. If I put a tape, I'll be harming her more. So what I want to highlight that whenever we put a tape, whenever we do an operation on them, at least an operation, we must be very, very satisfied that the diagnosis is right. And these can be some, I have patient, the patient is on diuretic, and the minute you stop diuretic, they start getting better. Similarly, patient of diabetes, you have to treat their diabetes, they will get better. So this is very, very important. We take detailed history of the patient. She may be on certain medication, we can change them. Like, patient on antihypertensive therapy with diuretic, so we can reduce the amount of diuretic. Or some patients are having, drinking 3 liters of water per day, 3.5 liters of water. They're thinking their face will glow with it, there is a concept this one, but whether face glows or not is doubtful, but the bladder glows and they leak urine. So excess of amount of drinking water is also not good. They have to have 1.8 to 2 liter, which is normal requirement. Next, please. Okay, yeah, so this is the IUGA and International Continence Society classification. Basically, we have already discussed it. So anything basically involuntary leak of urine on coughing or raised intra-abdominal pressure is stress incontinence, and if she has to go, that is urgent incontinence. So mixed means both. So we won't go into less of detail. Sometimes they can pass urine during coitus also. That is also usually part of SUI. Next, please. Okay. Yeah. Okay. So overflow incontinence as also be seen. So this is the basically like increased daytime urine frequency, then interruption of sleep, that means nocturia. Once, let me tell you, if someone gets up in the night once, even I get up once in the night, that is normal. But if someone has to get 2 or more than 2, then it is abnormal. And then urgency, compelling desire to pass urine, like, there is someone in the washroom and then I can't hold on, then it is a compelling desire, that's urgency. And overactive bladder syndrome, of course, again, urgency, frequency, nocturia, that is seen more in overactive bladder syndrome or urgent incontinence. But you must rule out urinary tract infection in them because the symptoms can be both. So, I mean, we get urine culture done. If that is negative, then only we use the term overactive bladder syndrome. Otherwise, the patient may be having UTI, which is easy to treat and, of it also. Next, please. Okay. So same thing again, we have already discussed hesitancy, slow steam, intermittency, staining to avoid position dependent, which is like you can skip it. Next, please. We have already done that. Yeah. So what is important is, I told before also, approach to a patient is very, very important. So I tell my patient, in fact, I keep this patient little later in my OPD. I tell that Mataji, you wait for some time. When I spend half an hour on each patient, if not less. Others, I mean, in 5 to 10 minutes we can see. So detailed history taking is very important. Told before also, one of my patients, a dentist herself, and from Rajasthan she came, and when I examined her, so she had an meningomyelocele at birth, and she was operated for that. And when I examined her, she hardly had any sensation, Dr. Haresh sir. And then I examined, so I touched it, and then so she was having problem. In that case, putting a tape or that will different, because altogether. Another patient of mine had multiple sclerosis. So please do take detailed history, especially neurological history, any drug intake history, and some patients are psychiatric patients having drugs for that, so they also can have effect on that. And of course, I told you before that, this patient on diuretics and all. So then frequency, nocturia, urgency, any voiding symptoms, I told you that, pulmonary disease. This is also important that some patient have chronic pulmonary obstructive disease, some patient have chronic constipation. The important is that even if I put it like the patient may have prolapse also. So even if I had a patient, she had hysterectomy, then she had vault repair done by outside, and she came with failure of vault prolapse. She said, Dr. Sharma, some new gynae colleague referred to me. So when I examined the patient carefully, she had massive vault prolapse. I said, I'll put the another, but why it failed? So when I went into detail, she had chronic obstructive airway disease, sir. So I referred her to Professor Randeep Gureli, our director, and I got her treated. For 3 months, I did not operate on her. Not that her COPD got totally cured, but it became under control. And then I put a laparoscopy, abdominal sacrocolpopexy for her. And ever since she has been fine, almost 7-8 years. So what is important is, sir, we first stabilize their medical condition, and then we do surgery. Similarly, patients of, any patients having raised intra-abdominal pressure like chronic constipation, I treat their constipation, because that even if I do vaginal hysterectomy on her, later on it can fail, she can come back with the vault prolapse. So this is important. Same way, even if I'm doing a tape surgery or I'm doing a burst, that can also fail if they have, around the clock like raised intra-abdominal pressure. So this is very important, that detailed history, detailed examination of the patient, including neurological examination. Next, please. Yeah. So again, complete examination, any abdominal examination, any mass impinging on the bladder. I mean, I had a patient last month, and I had to operate her. So she is doing such a massive prolapse, and then her bladder, as if her bladder will burst and come out. So it is just, I was shocked that I had never seen such thing. And then I examined her. Her uterus has got a big fibroid, which is impinging on it, everything. So, I mean, she has got a almost 18 to 20 weeks of fibroid, very peculiar situation. It is pressing on everything, and her bladder, urethra are coming out as if, I mean, she will have a fistula anytime. So I'm planning, like, we have admitted her, getting her, because she had because of that, she had renal AKI also and all. So then we'll operate. So I thought we'll do her, she can't be done from below because she's almost 22 weeks. So I'll do a combined surgery for her. So like that, so it's important. Sometimes there can be mass abdomen, which is pushing on everything below, including can cause SUI and all. Then pelvic examination for any excoriation, prolapse, atrophy, tone of pelvic muscle, demonstration of leak, cup stress test, bony test, causative test, pediatric Foley test. These are the various tests done for SUI to demonstrate that. And neurological examination, normally in gynae, we don't do neurological examination, but in patients of SUI and this urogynae, it's better to examine. I told before also, many of my patients had like neurological problem. So like mental status, anal reflex, bulbocavernous reflex, anal sensation, as the patient I was telling you about, the patient who had meningomyelocele surgery. And then urine analysis is important. Do look for bacteria, hematuria, and glycogen, because these patients may have, if they have UTI, then that can have symptoms similar to urgent incontinence, and we may make a false diagnosis of urgent incontinence. Similarly, post-void irregular urine is important. Ask the patient to pass urine, and then either you do ultrasound scan, or sometimes you may have to catheter also in a difficult case. So the amount should be less than 50 ml or at the most 100 ml. If it is more than 100 ml, it's definitely pathological. So we need to know the cause. Cystoscopy, MRI, CT, X-ray, not done for every single case, but sometimes in rare case we may have to do them. But it's actually careful history taking, careful examination is important, and sometimes we have to do urodynamics, which I'll be discussing. Next, please. Okay, so this is the, we can do a PET test. It's a very simple test. We did a thesis also. So it allows detection and quantification of incontinence. Like, 1 hour PET test means we make a pad, it's a sterile, and then we weigh it. Suppose it's 20 grams, and then we give the pad to the patient, and she keeps it for 1 hour. And then she walks with that in the clinic. So after 1 hour, we again check it. So, and we, during this time, she drinks 500 ml of water or some drinks for 50 minutes. So before and after drinking. So this can tell us then, and she does exercises also. So normally in a continent patient, they shouldn't be, it should weigh same. If you are 20 grams before, it should weigh 20 grams again. But if it weighs like, if she has leaked urine, so naturally it will weigh more. And then there is a grading also according to that, whether say 1 ml, 2 ml, 5 ml, so mild, moderate, severe. So I won't go into details of that, but this simple test, as a part of thesis we did in our thesis case. Similarly, dye test, this is more useful actually if you are suspecting any fistula and all. Next, please. Okay, so but it's bonus test or cups test, all of us are routinely doing it. So we examine the patient, like today only I heard the clinic. So I was telling my PG to stand on the side, otherwise urine can fall on us. And so we basically examine the patient with the full bladder, and then we put 2 fingers parallel to the urethra on either side. Ask the patient to cough, so she will leak urine. And when you press it slightly, not directly up, but on the side also. So this will, if the leakage stops, we call it Boni test positive. It will indirectly tell us actually that, when I'm doing a burst colpus suspension for her, this is the way I go actually. So that means I'll make it back this thing, so that if the Boni test is positive, and this also tells us that the mobility of the bladder neck, if the bladder neck area is fixed or, frozen and like fibrosed, then there's no point in doing birch. It won't be successful in that patient. In that case, you can still do tape, but not birch. So this is important to know whether we can do birch for her or not. So this is the Boni test. Next, please. But Boni test, because we are directly pressing on the urethra sometimes, so that can be, so this Miyazaki Boni test, this is, in that case, what Miyazaki said, that instead of putting it directly, we go anterolateral on both sides. So take a sponge holding forceps with some swab in that, and we, instead of pressing directly on the urethra, we go on anterolateral side on both sides and all. So this is, sorry. So this is what we do, and if it is a positive test, then there is a favorable outcome with the birch procedure. This is, and it is equivalent to birch colpus suspension procedure. Next, please. Okay. So, okay. Yeah, so this is the cautive test, or in this case, basically we are seeing the demonstration of the urethral hypermobility. So you can say in the normal patient, like, the angle is less, and in case of hypermobile, it is more. So if the hypermobility, the more than 30 degree, then it shows basically that cautive test is positive, and this goes in favor of basically urethral hypermobility, which is a type of variant of SUI. And these patients respond fairly well to a birch colpus suspension or even to tape procedure. Next, please. Okay, and pediatric Foley test actually resembles like we do in case of cervical incompetence, when that cervix becomes open. So same way, in a similar way, the intrinsic sphincter deficiency, it won't show the angle, but intrinsic sphincter deficiency. If you use a number 8 Foley is inserted in urethra without inflation. So normally, sir, it will the internal sphincter will hold on to it, but in this patient, if you try to pull it, it just comes out. So just like incompetence cervix, so there is an incompetence internal sphincter basically. So this also you can do, and again it will tell us a good outcome with colpus suspension operation. Next, please. So it will basically show the intrinsic sphincter, and then the maturation diary is more useful for urgent incontinence, but can be used for SUI. The subsurgeon doctor, they have made it. I mean, normally we do it for 1 week, but subsurgeon people have come out with this, that even if you do over the weekend, I mean 2 to 3 days, that is also good enough. So what is also important about it, it will tell us that what is the total input of the patient. We totally calculate, sir, for 24 hours, then another 24 hours like that. How much is he drinking water, or tea, coffee, and all, plus when is he passing urine, and then and when are the incontinence episodes, so and any change, wet pad, reason for incontinence episode. So if you keep it for 3 days, preferably 7 days, but even 3 days it can be good enough. So it can tell us, like one of my patients, basically and then I realized he was drinking 2.8 liter water every day. So, and when we stopped, and then I realized that, it was morning, I mean, between 9 a.m. and 12 o'clock was the main passage, because he was drinking in the morning and like that, similar in that. So like that, it can tell us what times he's passing even more, what times he's more incontinent, and when is he drinking more, like that. So we can guide it. And when I asked her not to drink water without any treatment, sir, she got relieved, because he was drinking 2.8 to 3 liter of water every day. And when he made it 1.5 to 1.8, her incontinence disappeared. So not that it will disappear in all cases, but some of the patients. So this can really be guiding you about that. Next, please. Yeah, and urodynamics, I mean, you don't have to get urodynamic done for every single patient. Even ACOG, RCOG both say that, but it can be useful, especially for complicated incontinence. And medico-legally also, basically, even a simple patient of SUI, we can do the tape, we can do birch without doing urodynamics. Similarly, urgent incontinence, we are treating medically, so no need to do urodynamics. But for difficult patient, or complicated patient, or recurrent patient, then we must do it. And sometimes, like some doctors are routinely doing it. They think it may be part of to avoid medical legal negligence. So it's not like we must do it in every single patient, but yeah, definitely in complicated patients we must do it. Next, please. So these are the basically indications. Next page, we already discussed with them. Yeah, discuss them. Yeah. So preoperative urodynamics is not needed for every single patient, and you can do uroflowmetry, cystometry, urethral function, voiding cystometrogram, and a very simple urodynamics you can do in your PV room itself. You take 1 liter of bottle, and then you attach that catheter, this basically IV cannula, IV tube to the catheter and put this. And when we fill the bladder with that, so depending upon how much is the bladder filled, we can indirectly know that, that's basically it was 1 liter from there. So if it is now say 800 ml left, so that means 200 has gone in the bladder. And patient will say, I want to pass urine. So that means she has got pulling sensation at 200 ml, 250 ml, 300 ml, and at 400 ml she said, I can't hold on, or this goes back into the goes back into the bottle. So that means she leaked urine at that time, indirect method. So this is simple urodynamic you can do in PV room free of cost, like that, But of course we can do like uroplometry, cystometry with the help of the full this thing, like our urodynamic people do it, and we are also having in our department. Next, please. So little bit I also say, yeah. So I mean, it will tell us about the flow rate, 15 to 25 ml per second, and like normal flow rate, and less than 10 ml is basically poor. And next, please. And normally, basically, yeah. So this is the one basically I was telling you, filling catheter, and of course normally we put so bladder pressure catheter will tell us about the pressure PV cycle. Similarly, abdominal will tell us P abdomen, and then we can reduce from PV cycle minus P abdominal with the P detrusor pressure, like that. And next, please. Okay. So this is what we do. Next, please. Okay, I won't go into detail of that. So like that, we can also actually it mainly tell us about the basically urge incontinence, that during the filling phase, ideally, there should not be any passage of urine. If the patient during filling phase, I mean, it goes back into that, that means the patient is having urge incontinence. So in other words, basically, urodynamic is more useful for urge incontinence rather than SUI. In SUI, basically, patient leaks urine on coughing, that you can see otherwise also. Aim is that we don't miss a mixed incontinence patient. Next, please. But they will give you the reports, yeah. Next, please. We have already done that, yeah. So these are the normal values, basically. Residual volume, normally urine 50 ml less. First desire, I told you about 200 ml. Capacity 400 to 600 ml. Maximum detrusor pressure, filling less than 15 centimeter of water. Voiding less than 70 centimeter of water. Peak flow rate normally is more than 50 ml per second. Next, please. Okay. So, I mean, so stress incontinence, we said almost anything between 5 to 69% patient, and 50% with SUI, with incontinence have SUI. Annual incidence is 4 to 10%. Next, please. So stress incontinence is one of the commonest, basically. Next, please. We have already done that. Next, yeah. Okay. Yeah, we have already done that. Yeah. Okay. Yeah, again. So basically in Maguri classification, I mean, type 1, 2 are urethral hypermobility. Type 3 is basically intrinsic sphincter deficiency, which you can check with that Foley's test. Next, please. Okay, so the management is basically non-surgical management. We start initially. So I mean, this is important whenever we are teaching our patient. First is non-surgical lifestyle changes. So I tell my patients, like, I spend 10 minutes with the patient on discussion, 10 to 20 minutes on talk, like examining, taking her history. Then 10 minutes I counsel her that, I will do 1 or 2 things, 4 things you have to do yourself. So she has to do lifestyle changes. Most of these patients tend to be obese. So that I said that you have to lose 5 kg in 1 year. Okay, then you have to do pelvic floor muscle training. You have to treat them. We take the help of our, physiotherapist also. So please, you have physiotherapist, train one physiotherapy in urodynamic, in urogyne, and then she can tell them better, because sometimes we don't have time. I personally also tell, but I involve one of my physiotherapists. And then drugs. In fact, I was in London last 2 years back, Dr. Niranjan was saying with Linda Cardozo's clinic, and I saw 1 hour that lady spent physiotherapist the patient, and I was amused to see one, apart from routine Kegel exercise, like, try to hold urine, try to hold motion, try to pillow between 2 thighs, try to squeeze fingers on my, vaginal muscles on my fingers. What you are telling that take a deep breath, like yoga. So when you're taking a deep breath, sir, diaphragm goes down, abdominal contents go down and touch the pelvic floor. Pelvic floor contacts, and then we exhale, sir, pelvic floor comes up. So in other words, like she said, with each breath, pelvic floor is contracting, going up and down. So you are doing more exercises. I was very amused that it is a yoga only. So our yoga can be useful for these patients also. She said that you can only do exercise for 5 to 10 minutes, but breathing you are doing whole day. So that will be more effective. Though I haven't done any study on that, but I was quite fine that, it is an interesting thing. So pelvic floor exercise, including yoga, are useful, sir. Drugs usually, to be honest, drugs devices, they don't work that well. They don't work that well in stress incontinence. They work more for drugs, work more for urge incontinence. Bladder drill and biofeedback also work more for urge incontinence, but some role is there I'll be discussing. And then of course surgical treatment is more. So in general principles, sir, urge incontinence is treated medically, and stress incontinence, especially moderate to severe, is treated surgically in general principle. But definitely for mild to moderate cases, we must first do the medical management, conservative treatment, and let the patient ask for it. Never impinge forcefully force treatment on her, because then she will be unsatisfied. That's what I do. So our waiting lists are routinely 3 to 6 months in AIIMS. So during that time, I give her, tell her to lose 2 to 3 kg weight, lifestyle changes, belly flow exercises, bladder training, to decrease tea, coffee intake. Sometimes I give her calcium, vitamin D also, and I give her one drug also, like fluoxetine. And after 3 months, I assess her. And during this time, her turn has come for the surgery. I asked her, how are you? She said, Dr. Sharma, I'm much better, almost 30 to 40% relief, and I want to try this medical service. By all means, we are not hungry for doing surgery on you. So, so like that, I mean, many, almost 50-60% patients don't even ask for surgery. They say, I want to try medical management or conservative treatment or physical therapy. I said, fine. Those patients in which it didn't work, like severe incontinence, moderate incontinence, or those who are frustrated, then we offer them surgery. So, I mean, surgery should only be offered when the patient asks for it and she is really suffering with moderate to severe. Don't do it for mild cases and all. And, so that our consent should be clear that we have exhausted all, conservative managements. Next, please. Okay. So we have already discussed lifestyle changes, weight reduction, decreased coffee, fluid, bladder training. Next, please. Yeah, they will work for urgent incontinence. So physical therapy, I have already discussed. Kegel exercises are very good. I tell the patient, the exercises cost nothing and they are good for health anyway. Otherwise, also it will keep her, abdominal muscles also into, tone, urethral muscles, bladder muscles, and all that, perineal muscles. It is good for health. But she need to do it at least twice a day, 15 minutes each. Next, please. So, and and almost 3 to 6 months she can do, and she can keep on doing it later on also. There is level 1 evidence that this pelvic floor muscle training is effective in treatment of SUI, especially mild to moderate cases. Next, please. But she should do it properly. I mean, sometimes we get patient that I have tried it for 2 weeks, 3 weeks. So wait for at least 3 months, sir, and let her do it properly. It's not sometimes just 1 or 2 minutes she did it. Biofeedback can also be used, but not a must for that. Next, please. Yeah, vaginal cones, basically we are not having them in India. They are costly, 200 to 300 pound. But the aim is here basically like she keeps a cone, and initially bigger cone, then smaller cone, because her muscles, so her basically by gravity the cone will try to fall off, but her muscles will contact, they will try to keep it up. Next, please. So it can be tried. Basically, electrical stimulation also, we are not routinely doing it, but can be done sometimes. Next, please. So those people who are doing special clinics for that and all. Similarly, these, the crutches like Suez ring, incontinence, they are not very, very common available and not really very effective, but just to complete the list. Next, please. Yeah. Next, please. Yeah. So medical management, unfortunately, doesn't work that well for stress incontinence. It works brilliantly for urgent incontinence. Okay, but there is only one drug, duloxetine, and the dose here written 40 to 80 milligram. But let me tell you, I never went beyond 40 milligram. So my initial dose, I always give 20 milligram once a day. Try it for 3 months. If patient during this time she is decreasing tea, coffee, she is decreasing water intake, she is doing pelvic floor exercises, she is reducing, doing bladder training also, and I give her 20 milligram a day. I go up to 40 milligram a day. 80 milligram is too much. No, that's all I do. And but it can work in some patients. It is selective serotonin and norepinephrine reuptake inhibitor. But this is the only drug which works. Others don't work. Next, please. Okay. So, but it can sometimes, there may be some dry mouth and but subjective improvement is there. But like you can try it for mild to moderate case. Next, please. Okay. Again, next, please. Yeah, sometimes some people are doing laser therapy, but I don't personally use it. Yeah. Next, please. Can be done. Yeah. Next, please. Yeah. Same thing basically. Some laser treatment. There is some role of these basically. Next, please. Okay. So mainly, to be honest, actually many of the patients, 70 to 80% patient, especially moderate to stress incontinence, will require surgical option. And I advise that you be expert in 1 or 2 surgeries basically. Rather than trying to do 10 surgery and be good in that. So either I do like Birch Colpo suspension, and you can do laparoscopically also, but little bit slightly longer learning curve, and then tension-free vaginal tape in the patient who can afford. Next, please. I'll just quickly read through them. Yeah. Next, please. Yeah. Kelly stitch we don't use that much. So the initially MMK operation was there in which we tied with the pubic symphysis, but that causes osteoarthritis is obsolete now. So Birch Colpo suspension is the modification of that. This is what we do actually. Next slide, please. I'll just show the slide for that. Birch, yeah. So this is Birch I'm using a lot, and it is coming back because of the controversy about tapes and all. It went into less use because of the availability of tapes. But now because of this adverse publicity of the tapes and mass erosion problem, it is coming back. So we keep the patient in semi-lithotomy position. Assistant sits between the two thighs. We put a Foley's catheter from below, sir. I open the abdomen by transverse incision, slightly below the penicillin incision. I don't open the basically peritoneum, but I work in the cave under the pubic symphysis. I try to find out the bladder, urethra, and then in that area, I lift basically on one side. My assistant from below is keeping a sponge, holding forceps sponge. Hold the fingers, he lifts one side, and then from above, now there's a Foley's catheter inflated 8 ml into the bladder. So what is important now, from above I am feeling, so this distended thing is bladder, and this is tube like thing is urethra. So how to know the bladder, like distended basically Foley's catheter is bladder neck, catheter itself is urethra, sir. So I hold the bladder neck with my index and middle finger like that, and then the assistant lifts one fornix for me. And then I take a stitch there, not into the urethra, not into the bladder neck, but very close to the bladder neck in the vagina. Thick tissue of the vagina, but not up to the vaginal mucosa because it's a non-resolved stitch. So I take 2 stitches on the left side and 2 stitches on the right side. And then I come back out a bit, and then this is the pubic symphysis. Lateral to pubic symphysis is the Cooper's ligament. Okay, that is about 2 centimeters on the superior pubic ramus. So this, and I keep that needle with the stitch. With that, then, so one stitch here in the vagina, then on the Cooper's ligament of the same side, other stitch, then Cooper's ligament, and then repeated on the other side. So now my assistant comes to the right side. So basically 2 stitches I put on either side. Some people put 3 also. So the stitch has to be put in the vagina, at the bladder neck, not in the bladder, not in the urethra, but close to them. And then we tie it from below. So when I'm tying it, it shouldn't be very tight, sir. Otherwise, the patient can have difficulty to pass urine and like that. And then, so we just basically bring the bladder neck toward the, near the pubic symphysis, just gently, not too tight. Otherwise, patient can have, difficulty in passing urine, which will be difficult to treat that. So this has, and so what in other words, we are coming back to the same thing again. That means this proximal urethra, sir, which had gone outside the abdominal cavity has come back to the abdominal cavity. So now the raise in the abdominal pressure will be communicated to it, and patient will not leak urine. That is the aim, and that it works brilliantly. The results are 85 to 95%, even up to 5 to 10 years. And it is coming back. It doesn't cost like in Professor Niranjan's hospital and my hospital. Basically, that we can do it free of cost. Patient needs to stay for 4 or 5 days, but catheter we keep for almost anything between 72 hours to 5 days, sir. So this is there, and then just routine antibiotics like ciprofloxacin, tindazole, whatever you want to give, but keep the catheter for at least 72 hours, sometimes to 5 days. So it's a big operation, larger operation, but results are excellent, and it's almost free of cost. And now because of non-availability of tape some places, so this will be back. In fact, I went to 2 years back to Linda Cardozo's clinic and all, and when I asked them, they didn't have tapes, sir, with them. And they say, in fact, I ended up in teaching them birth colpo suspension because I never stopped doing it, like in my hospital, those who couldn't afford tapes, we used to use birth. So I never stopped doing birth. I was doing one birth every, if not one every month, but in 2 months, 3 months. So 5, 6 births I'm doing every year. So I never stopped, sometimes more than that also. Next, please. So it is coming back into vogue. Same thing, basically, again. Next, please. So you can do it laparoscopically also. Okay. And it is excellent operation, basically. And only thing slightly bigger operation as compared to tapes. But results are long-term data is one of the highest. Next, please. And of course, yeah. So 90%, 70%. Next, please. Sometimes they can be wording difficulty. You can avoid by not making it too tight. Next, please. Yeah, we have done that. Yeah, next, please. Next, just study. We have, yeah. Okay, so then came the tension-free vaginal tape. You can do it like abdominally, and then you can, but for that you have to do basically it make it 1 to 2 centimeters on the anti-vaginal wall, separate the urethra from the vaginal mucosa, and then we put the tape on either side anti-abdominal wall. So, okay, and this is the basically TVT, but in this case, there is 8% risk of bladder injury. Of course, there is nothing major thing, even if it injures the bladder, you don't have to do laparotomy. You just withdraw it, do a cystoscopy, withdraw it, and go lateral to that. So, but still 7 to 8% bladder injury rate is just unacceptable to all gynecologists. So then the tension-free op-tape came. So we started using op-tape. In that case, there is no risk of bladder injury. Next, please. I'll just so quickly do some slides. Yeah. So TVT gained, it is a good success rate, almost equivalent to birth plus smaller operation. And next, please. Yeah. Okay. So, but there was a risk of bladder injury, sometimes infection and all. Next, please. So this, yeah. So then came TOT. I said in this case, we same operation, but going into the obturator foramen on either side. Next, please. I'll show you some slide. Yeah. Next, please. Okay, yeah. So this is the basically activity. So you can say we put a 1 to 2 centimeter diseases, separate the vaginal mucosa from the urethra. Then we put the guard, and on either side, basically, I'm putting this needle going on the right side, left side, and ultimately this tape. So it will come through the obturator foramen on either side, and we just cut it close to the skin basically. So the tape will sit at the mid-urethra level. So again, the results of TVT-O are almost same as TVT minus disadvantage. That means no risk of bladder injury. Risk of urethral injury also less. You can do inside out, sir, as well as outside in, whatever, both are equally good, whatever you are trained in. I tend to do more inside out, Johnson & Johnson, I'm more confident with that, but both are equally good. There is one Indian version also available, but I mean, sometimes you have to check the quality of that. Next, please. Okay, same thing. This is how we pass it basically, and this ultimately tape sits down. Yeah. Next, please. Yeah, that's fine. So same thing basically. You can teach the students in the model, value model. Next, please. Okay. Yeah. Next, please. Same. Just quickly we can. Yeah. So both are almost equally good, but TVT causes more bladder injury, so we don't use it anymore. Next, please. Yeah. Okay. Next, please. Yeah. But results were almost equally. Cochrane also says equally good results. Next, please. Okay. Yeah. Okay. So then they came with big bang, and we thought that other operations will disappear, but unfortunately then came the big bang. This mass erosion, adverse publicity, US FDA warning. So now the tape. I mean, when I went to UK, the tape was not available. In India, they're still available, but to lesser extent. So next, please. So yeah. Okay. Yeah. Next, please. Okay. Yeah. So these are the different types of tape. Next, please. Okay, so now basically, though the tape was very good, I personally had excellent, results with the TVT and TOT both. And there was, I mean, I had 2 patients, one in fact wife of a deputy commissioner of police who had mass erosion, but we just cut that eroded part and the patient became all right. Another patient, one senior manager in State Bank of India. So probably she had actually menopause and her vagina was thin. So you have to be certain that you make the vagina better before putting the tape, because it comes out. So mass erosion is a problem, and adverse publicity. So in UK, US, and there is availability less. So same thing will happen to India also. So these pubovaginal sling were very popular about 50 years back. They went down to disrepute, and because they were a bigger operation, but now they have come back again. So you can use autologous fasciolata, you can use heterologous or synthetic. We shouldn't use now. So I mean, so we came back. I gave a thesis to my PG student. Next, please. Yeah, so we can use it again. Next, please. So you can use fasciolata, but rectus fascia saying we are more comfortable, because like all of us are doing the Purandesh Rhycopexy, Professor Niranjan also is doing that. I am also doing it, that Haresh sir must be doing. So we are used to that, sir. So what I do, sir, I cut 8 centimeter into 2 centimeter tape, this rectus sheath, and with that I'll be just showing. So we gave this thesis to, next please. So autologous facial sling. So you can say made an incision transverse, and with it, like I made it 8 centimeter into 2 centimeter rectus sheath I cut. But you need to make a good dissection, because from this patient. So you just cut it from both ends, sir. Next, please. And yeah. So ultimately, this is the how. And vaginal mucosa, I made it 2 centimeter incision to 2.5, and from above I put the a basically long artery forceps, or you can say clamp on either side. But the patient is in lithotomy position, and I made a 1 centimeter incision, 2 centimeter on the vaginal mucosa, separate the urethra from the vaginal mucosa, and did dissection up to inferior pubic rams on both sides, just like in tape. And from above, then I put the long artery forceps, sir, or clamp, and then from below this basically the rectus sheath at the end. I put 2 nylon stitches on both sides, and from above then I just pulled those nylon stitches. So ultimately this came anteriorly, just like on the anti-rectus sheath, and I just tied it to the anti-rectus sheath and kept a artery forceps so that's not too tight. Okay, so just keep it there, and then it had no blood supply. So ultimately it will work, and it is the patient's own tissue. There is no chance of rejection, no chance of erosion, minimum chance of erosion. Only thing is a bigger operation, and you are doing dissection in that area. So initial 1 or 2 of my patients, they had some fluid was coming, so we had to leave the drain for longer. So keep the drain for 48 to 72 hours in that area. And when you're doing dissection, do it properly on both sides, sir. That is important. Next, please. Yeah. So at mid-urethra, results are good, and this is ultimately we are tying it basically to the anti-rectus sheath. Next, please. So almost it's like TVT, but we're using the patient's own tissue, which is free of cost. Only thing, operation is slightly bigger as compared to TVT and all. And initially, we had some topics, like one patient had difficulty in passing urine. In one patient, we had to keep the catheter for 5 days. In one patient, almost 2 weeks. But after initial hitches and all, and put it in the mid-urethra, not at the bladder neck, because with bladder neck, the chances of difficulty in passing urine are more. So we got good results. Now we had done almost 22 cases, sir. Our and first 15 cases compared it with TVT was published in European Journal of Gynae. Next, please. I'll just show you some. Yeah. So this paper was already published in the European Journal. It was appreciated also, sir. Our thesis paper. So we found the results excellent, and it is free of cost, and patient's own tissue. And now with the non-availability of the like TVT tape and TVOT, so this stands a good chance, sir. Next, please. And then, I was our Jogi editor, madam, basically invited me. So I wrote a autologous facial sealing for surgical management of stress incontinence, a comeback. So it has published in our Jogi journal also, editorial on this mind. Next, please. Okay. So then anti-colporepy, just we don't use it anymore. But, along with like if some patient Mataji has got say 3rd-degree prolapse and, coming from a village, can't afford anything. So a small, all of us have done Kelly's repair easily. So you can combine that with it for mild to moderate. But to be honest, actually moderate to severe incontinence, I tend to combine it with the TVT or TOT and now with the tape also. Next, please. Okay. Needle suspension, just to complete the list, we don't use them anymore. Next, please. Yeah. Okay. Same way, peripheral bulking agent, again, I mean, we don't use them anymore, but they are available in UK and especially for intrinsic symmetry deficiency. Unfortunately, they are basically the bulking agent disappears, collagen tissue has life of only 6 months to 9 months. So you have to repeat it again and it costs 200 to 300 pounds, sir. So by Indian circumstances, like my patient, Dr. Niranjan's patient, Dr. Haresh patient, they may not be able to afford it. And so didn't like, and some patient may have difficulty in passing urine also. So it never picked up in India. Next, please. Yeah, same thing. Next, please. Yeah. Okay. Yeah. Artificial sphincter, just as a last, cost 7-8 lakh rupees equivalent to that. So as a last resort, I have never used it personally, but I mean, as a last resort, just to complete the list for postgraduate student. Next, please. Yeah. Okay. And future trends, of course, are like, stem cells, and also there may be some role of stem cell therapy for this also in case of SUI. And there, I mean, in some studies, almost 88% improvement of objective symptom. Next, please. Yes, I think I have finished. Thank you very much, sir. Thank you.
Thank you, sir. Wonderful lecture. I just was present for the MS exam in one of the universities for the students, and basic questions were asked to them about Q-tip test, Boney's test, different type of SUI procedures which are done, and MMK, Marshall-Marshalls, Kelly stage, Colpo suspension, and I can go on and on. But I'm sorry to say the younger generation, it's not that I'm trying to ridicule them, but the younger generation probably have lost interest in the history of, you remember, sir, we teach them history, introduction, father of myomectomy, father of ultrasound, father of SUI. Probably we will also be in the same boat after 30-40 years. Nobody will remember us. Only YouTube people will be seeing us. Chandrawati madam, Haresh Doshi sir, J B Sharma sir. So what I went through today was an encyclopedia of SUI, and really you have covered the whole topic, including the recent advances and also
Wonderful, yeah. JB, it was wonderful, JB.
Thank you. Thank you.
So I request now Dr. Haresh Doshi sir to give his expert comments. And
thank you, Dr. Niranjan. Yes, you are right.
Yes, thank you, sir.
Sir is a stalwart professor, and the exhaustive material he has put in a precise, comprehensive, and compact manner in a very short time. Right. I would make few comments that he rightly stressed that patients are shy of giving this symptom to you. So I want to tell, Sharma ji says, "Sarm mat rakhna." When you go to gynecologists, you have to tell that. And if the patient does not tell, you have to ask the leading questions. That is very important. Normally, our focus is on gynae, I mean uterus, and we forget the bladder symptoms. So we must. A nice slide he has put of the approach to the patient in a detailed manner, as Niranjan also told, that people are not taking the history. That history part he has nicely mentioned, that big slide, and he discussed it also. Urodynamics, again, we were told that you have to do, but he said guidelines does not recommend it, but for medical legal purpose, you may do it. Then also clearly differentiated between the treatment of urge incontinence, which is medical, and stress incontinence, surgical. But sir, again, the stress incontinence, you gave the 5 option of medical treatment also, not
Yes.
surgical. That is right, lifestyle changes, caffeine intake, devices, drugs, and like so on. So all this put together may have a good results, and patient may have to altogether avoid the surgery once in a while. Right. So that is there. I want to ask you 2 questions. Is there any genetic component in SUI, sir? Genetic component, family history.
Yes, sir, there have been some studies and they say just like some people have poor collagen tissues, or just like you see nulliparous prolapse peculiar to India, in which we are doing pronarothoracic Khanna sling operation or
Right.
improved operation. So same way, I mean that same collagen tissue may cause this area also weak. So those patients who have like nulliparous prolapse, so same way they can also have urinary incontinence. So there is some, but we don't have definitely long-term studies and too many studies of
Okay.
it. But there is some role.
You said the etiology, pregnancy and post-pregnancy means delivery. That is the most important reason. We cannot avoid that. So have you any preventing measures for SUI?
Yes, sir. Actually, a preventive measure is just like, sir, we avoid difficult forceps, we avoid difficult deliveries. But I'm not recommending that we should do cesarean section blanketly, because cesarean section has much more morbidity. And even if the patients who have been pregnant, sir, even if they had elective cesarean section, they still can have, because pregnancy itself also causes like relaxation of the ligaments and all
So
that.
it is not totally protective. Cesarean section
So definitely, sir, there is no doubt about it that someone having elective cesarean section and all, so the chances of SUI will be lesser in them as compared to delivery. But we have to have a judicious and middle path, sir. I mean, we avoid difficult forceps, we avoid difficult deliveries and all, but we can't recommend blanket cesarean.
We do it this.
Yeah.
Right. Because I was interested to note that yoga is also helping increasing the pelvic muscle.
Yes, sir, absolutely. When I was surprised that, and I learned it from UK. Can you believe it, sir? Like, I mean,
yoga.
Doing it,
Great.
Yeah.
Thank you, sir. Thank you very much. Thank you very much.
It's a pleasure.
Thank you, Haresh Doshi, for those wonderful expert comments. Sharma ji say sharam nahi karna.
Thank you.
Chandrawati madam, your few words of wisdom.
As I told Sharma that I was really hypnotized to listen to him.
Thank you.
और हम लोग तो रोज ही यही डील करते हैं, यही काम हमारा आके. पर as Harish said, that the women are more open to us when they see a women gynecologist. Sometimes they hesitate to tell these things to the male gynecologist, but many times you need to do a leading questions and ask them, because women have a tendency to hide these things. They feel that this is something their weak point, probably other women don't have it, so they should not come out with all these complaints. But when you really ask them and talk to them, or sometimes when you examine them, you find a cystocele, you find a lax vagina, you need to ask them leading questions sometimes. Do you have some problem with this also? And then they come out with this problem. And JB has really taken us through the whole picture, very clear about the medical management and the surgical options. And I really feel we need to avoid surgical options for some time till we give them a full time to be on the lifestyle changes and medical treatment.
Thank you. Thank you.
Thank you. It was a pleasure to listen to him.
Thank you.
Thank you, JB sir, and all the esteemed faculty, chief guest, and our guest of honor, Dr. Haresh Doshi sir. Now we move on to the next speaker, and that is my dearest friend, Dr. Atul Ganatra sir. Atul is the FOGSI Vice President. Just he finished his tenure, and presently the Joint Secretary of Indian Association of Gynae Endoscopy. He practices at Jupiter and at Fortis Mulund Hospital. He has an immense experience in obstetrics, in gynae endoscopy, in surgical sepsis, and is a very down to earth and to the point. He has also got the largest series which we have presented now recently of the number of cases which India has got regarding COVID, and also has been the part along with Alpesh Gandhi and Parikshit Tank for the COVID guidelines which took place last year and this year. So Dr. Atul Ganatra, I asked him what would be your favorite topic, So he only suggested that yes, surgical sepsis. I said, is it going to be something very interesting? Yes, I am going to show some wonderful cases to discuss, and we are going to go, because now what has happened is, apart from COVID, we are also having patients post-operative complications with infections, gapes, etc. So I think to deal with them, we have the best person of our obstetric gynec society presently. And I welcome Dr. Atul Ganatra. Without much ado, the floor is yours. You can take your own time, sir.
Thank you, Dr. Niranjan, for inviting me. Can I share my slides?
Yes, please.
It's an honor to speak in front of.
Atul, I just wanted to wish you good luck. Niranjan, मैं पूजा में जाना मुझे IMA की. Can I leave with your permission?
Yes, madam. Yes, yes. Thank you, madam. Thank you so much.
I wanted to just meet Atul and just say bye to him and then go.
Yes, madam.
Hi, Atul.
मैडम आप रहे तो थैंक यू
क्या करें, पूजा वाले
बहुत अच्छा
IMA
लगा।
वाले मेरे पीछे लगे हुए हैं, वहाँ उनका आरती का टाइम हो गया, मुझे दौड़ा रहे हैं।
आपका आशीर्वाद हमारे सर पर बना रहे मैडम, और आप
100% वो तो बिल्कुल ब्लैंकेट आशीर्वाद है, बिल्कुल।
थैंक यू वेरी मच।
थैंक यू।
Thank you, madam.
Thank you.
Thank you. Thank you.
फिर मिलते
I might have to join for an operation, but मैं थोड़ा सा join करके।
So thank you very much, Niranjan, AGOG, and I was asked to speak on surgical sepsis. Haresh bhai, good afternoon.
Good afternoon, sir.
Atul bhai, full screen kare na.
Yeah. So this is one of my favorite quotes, and I think this happens to me every day. Once you stop learning, you start dying. WHO released the superbug list and said most of it is present in India, and many experts in Delhi, top super specialty hospitals, including AIIMS, say instances of infection are becoming common due to antibiotic resistance. The government has set an ambitious target to improve national health by 2025, and this is the SDG and the MDG goals that we have. Life expectancy, under 5 mortality, infant mortality, neonatal mortality, and of course, SSI. This is the patient who came to us 6 months after delivery. She had a cesarean section and says, I was admitted multiple times to a major hospital in Mumbai. And I was admitted for about 3 months on 3 occasions, but this is the status of her wound. We got her cultures done, gave her antibiotics, and after a month of treating her medically, did her secondary suturing, and this was the result at the end of 3 months. Another patient, as you can see here, wound sepsis, gaping of wound at a major hospital again. With so much of pus draining there, so much of dead tissue, we did not think it was right to do a primary closure. So we did a VAC dressing, a vacuum dressing on her. And as you can see, this is the VAC wound. And then once we were sure that all the sepsis is healed and healthy granulation tissue was growing, we did a secondary suturing on her. So I think there are systems in place and we must follow our systems. Another patient, international patient, who was referred to us, who was on a prolonged Ryle's tube and on a ventilator for a serious disease, landed up with a fungal infection of the nose. And now, of course, we know mucormycosis very well, but this is the pre-COVID times. This is one of my own patients. When we were using Sidex, we had atypical mycobacteria growing here, a sinus draining. And since then, we have stopped using Sidex. We never had problems with formalin, with Sidex. And then it was found out by the microbiology department of Hinduja Hospital, Dr. Camilla Rodriguez, that it is the tap water in Mumbai sometimes had the atypical mycobacteria. So we would wash our instruments with tap water, put them in Sidex, and then remove them. And since then, we have not used Sidex at all, barring our telescopes. And the minimum soakage time of the telescope is about 4 hours. So we need to follow evidence. False evidence can be alarming, can be difficult. And of course, the principle, first, do no harm, premium no share. This is taught to me by my mentor. So I'm going to be talking on surgical prophylaxis and surgical site infections. It will be beyond the reach of the timing that has been provided to me to speak on surgical sepsis or septic shock in detail. But hopefully, Niranjan will give us another opportunity for that. Patients farted, and that fart sparked a fire during a surgery in a hospital. This happened in Tokyo. So anything that happens to the patient, the hospital or the doctor gets blamed to it. He finds that doctors bow or tie a rule to reduce healthcare infections. Doctors' white coats, neckties spread dangerous infections. And I think now we know with COVID times, I haven't worn a tie in over 18 months. And otherwise, from 1994, I was wearing a tie every day because you don't wash your ties every day. And the simple principle of COVID last year was what you cannot wash, do not wear. And that's why I still am in my scrubs. The definition, the term nosocomial comes from two Greek words, nosis meaning disease and chemion meaning to take care of. Disease contracted by a patient while under medical care. Nosocomial is equal to hospital-acquired infection caused by organisms that are resistant to antibiotics. Infection not present or incubating prior to the patient being admitted to the hospital, but occurring within 72 hours of admission to the hospital. An infection contracted by a patient or a staff member while in the hospital or a healthcare facility and do not present in the incubation period, WHO. Healthcare associated infections and hospital-acquired infections are two important terminologies that we need to remember. Hospitals provide a breeding ground for drug-resistant bacteria which can be transmitted due to poor infection control practices in the hospital. CDC estimates that nosocomial infections contribute to 0.7 to 10% of deaths and cause 0.1 to 0.4 of all deaths occurring in hospitals. 10 to 30% of these patients admitted to hospitals and nursing homes in India acquire a hospital-acquired nosocomial infection against 5% in the West, according to members of the Hospital Infection Society, that is HIS of India. But this is an alarmingly high number. So we need to do some simple things to prevent this. In America, the CDC and prevention estimated that 1.7 million hospital-acquired infections occur from all types of organisms, including bacteria and fungi combined, and cause about 99,000 deaths every year. Mind you, 99,000 deaths. In Europe, 25,000 deaths caused by gram-negative infection. And nosocomial infections can cause severe pneumonia, particularly those on the ventilator, and infections of urinary tract, bloodstream, and other parts of the body. Many types of infections are difficult to treat with antibiotics. In addition, antibiotic resistance can complicate treatment. Burden of endemic healthcare associated infection in developing countries.
Please have some water. I'm sorry.
Yeah,
I think that would be better.
Yeah. Surgical site infection was the leading infection in hospitals, a pooled cumulative incidence of 5.6 per 100 surgical procedures, strikingly higher than the proportions recorded in developed countries. The gram-negative bacilli are the most common, and we know E. coli is the biggest bug for gynecology. Apart from methicillin resistance, 158 of 290, almost 54% staph aureus isolates, were very few articles reported of antimicrobial resistance. Clean care is safer care, and this is the motto that WHO wants to follow. And the global guidelines on prevention of surgical site infection, the first ever global guideline came in November 2016. And this included 29 concrete recommendations distilled by 20 of the world's leading experts and from 26 review articles. And this article in the Lancet is something that all of us must read on SSI. So what is a hospital-acquired infection? Hospital-acquired infection occurs up to 48 hours of hospital admission and up to 3 days after discharge, up to 30 days after an operation in a healthcare facility when someone was admitted for reasons other than the infection. So it could be 10% hospital care associated infection, impact on infection prevention and control, 30% effective infection prevention. Campaign, save lives, clean your hands. This is something that even COVID has taught us. More than 50% of surgical site infections can be antibiotic resistant. So what we need to do is to improve our infection control practices. Germs are a part of everyday life and are found in our air, soil, other parts of our body. Some germs are helpful, others are harmful. Many germs live in and on our bodies without causing harm, and some even help us stay healthy. Only a small proportion of germs are known to cause infection. Now, how does an infection occur? Three important things. An infection occurs when germs enter the body, increase in number, and cause a reaction. Source: places where infectious agents, example, sink surfaces, human skin. Susceptible person with a low immunity, could be diabetic, could be antiretroviral therapy or chemotherapy. Transmission away of germs are moved to the susceptible person. And the source of an infectious agent or germ and refers to a virus, bacteria, or a microbe. In healthcare setting, germs are found in many places. People are one source of the germs, including patients, healthcare workers, and visitors and household members. And that is why in the COVID time, we have restricted relatives. Important factors: age, immune status, underlying disease, diagnostic and therapeutic interventions. Most common type of HAI, that is hospital-acquired infection, is urinary tract infection. And that is why I wish I could show you a video of how we catheterize our patients in the OT. A surgical site infection, gastroenteritis, meningitis, and pneumonia. Wound infection presentation. SSI, that is surgical site infection, is a difficult term to define accurately because it has a wide spectrum of possible clinical features. And they can be incisional, which can be superficial or deep, or organ-space surgical site infections, which affect the rest of the body and other body areas as well. So to classify them as superficial, deep, and organ spaces. Etiology: all surgical wounds are contaminated by microbes, but in most cases, infection does not develop because of innate offensive. Host defenses are quite efficient in the elimination of these contaminants. Complex interplay between the host and the microbial agent and surgical factors ultimately determines whether the patient will present with sepsis or no. Remember this, it's very, very important. Most surgical site infections are contaminated by patient's own endogenous flora, which are present on the skin, mucous membrane, or hollow viscera. The traditional microbiological concentration quoted as being highly associated with SSI is that of bacterial counts more than 10,000 organisms. This is very important, and this is something we need to show our patients. SSI are not extinct entity, and they account for about 14 to 16% of estimated 2 million nosocomial infections, even in the United States. Salmonella, organisms. And if you look at the percentages, staph, coagulus negative staph, enterococcus, E. coli, and many, many other organisms we've already mentioned. In the ICU, fungal infection is extremely common. That's why we need to take extreme caution while prescribing an antibiotic. 33 to 67% of infected wounds are cultured. 15 to 20% of SSI caused by and amikacin shows resistance to about 50% of this. It's very, very commonly used antibiotic in gynec practice. Amikacin, it is resistant in about 50% of cases, particularly in urinary tract infection. Cefoperazone and sulbactam combination is resistant in 30%. And imipenem, the very, very common meropenem, resistance is seen in about 10% of patients. Sources of surgical site infections could be endogenous, air current deposit of contaminated particles, direct contact of microorganisms from contaminated hands, instruments, or implants. So please see that when you're taking rounds, you use a sanitizer. Of course, now it's very, very popular between each patient. So while you touch the first patient, in between each patient, and if you've obviously touched a patient with infection, you obviously hopefully have worn a glove, but even then use a sanitizer. Hematogenous seeding from a pre-existing infection to a remote site. Bacteria released into the wound when non-sterile body sites are entered. Patient's own skin flora. This is extremely common as well. Pathogenesis, inoculum of the bacteria, determinants of infection, host defenses, and wound microenvironment and virulence of the and the virulence of the bacteria as well. Diagnostic workup, the first and the foremost thing that we need to do is to clean that area properly, use an alcohol rub, take cultures. Clinical presentation, biological studies, imaging studies, histopathological studies come a lot later. The first thing that we need to do is the blood culture or site culture or a pus culture if you have a patient. Risk factors would be age, diabetes, hyperglycemia, obesity, tobacco, malnutrition, nasal colonization, pre-existing remote infection, compromised immune status, perioperative transfusions, prolonged preoperative hospital stay. So if you have a patient of low hemoglobin, I think you may do a successful surgery with very little blood clot, blood loss in a lab, for example. But what about her body resistance to catch these infections? The most common being as urinary tract infections. Like even a vault bleeding post-TLH is common in these patients sometimes. Operative wound, procedure related, operative wound class, patient skin preparation, preoperative shaving. One does not need to do any shaving. We should just clip the hair. Perioperative hypoxia, that is very important. So the saturation of the patient is extremely important. And that is why the hypoxia of COVID is something that has to bother us. The duration of surgery, surgical technique, postoperative hematoma. So drain is to be placed or should be placed in any surgery where you feel that there can be a collection. Lap myomectomy, we need to be very cautious. I think the barbed suture has done a wonderful job. I see very, very few postoperative hematomas when we use barbed sutures. Keep surgical drains whenever there is a risk of oozing. Suboptimal timing of antibiotic prophylaxis and traffic in the operating room. Very, very important that the door of the operating room does not open again and again and expose the air, and the air should be going out of the OT, not entering the OT. I think a negative pressure OT is what we call it. Surgical site infection, appropriate use and timing of the antibiotic is very common. Prophylaxis is the single most important intervention. If the perioperative antibiotic is administered after the incision, the risk of surgical site infection is sixfold when it is administered 2 hours or less before the incision. So ideal is to be giving the antibiotic at the time of induction of anesthesia, not more than 30 minutes prior to surgery. Reporting surgeon-specific SSI is also an important point in reducing nosocomial infections. How do we prevent? I mean, Fortis, we have this infection control book. And every faculty, for example, in gynecology, there are some fixed antibiotics which we are allowed to give by the infection control department. If I happen to use any other antibiotic, I have to report it to them prior to the surgical procedure. Implement comprehensive policies and procedures, minimize perioperative hospital stay. If necessary, shave the planned operative site, use clippers, not razors, and shave immediately before the procedure. Use antibiotic prophylaxis only when indicated. Provide sterile instruments which are individually wrapped in sterile packages. Use an effective antiseptic such as iodine. Now they say that's the alcohol, chlorhexidine is the best to prepare the surgical site. Include perioperative scrub with the antiseptic scrub for hand and forearm antisepsis for surgical teams. So once we wash our hands, once we scrub, we have this tendency to pick up the gown and wipe that area with our gown. That is a tap water coming from a BMC tap. We do not know when it was sterilized, the overhead tank. And we are using our gown to wipe that area. That's just not acceptable. We have to use a napkin to dry that area, use a hand sanitizer, use an alcohol rub, and then pick up that gown. We cannot pick up the gown directly. I think these are some important things that we need to remember. So clean hands and arms up to their elbows with antiseptic agent. Clean hands with soap and water or an alcohol-based rub. If indicated, remove some of your hair immediately before surgery using clippers. Wear special hair covers, masks, gowns, gloves during surgery. When indicated, give antibiotic before the surgery starts. In most cases, within 60 minutes, surgery starts and the antibiotic should be stopped within 24 hours of surgery. And we have this tendency of giving monoseph, amikacin, metrogyl for 5 days. And then we start an oral antibiotic, just not necessary. We give the last antibiotic after that. Clean the skin and site of your germs. forget who work demonstrated that washing drastically reduced the number of women dying after childbirth. And this took place in 1840. I think this is something that we need to remember. Just by simple hand washing, they brought down the maternal mortality, which was as high as 40%. This is the golden age of microbiology. All of them, including Joseph Lister, who practiced antiseptic surgery. I think Niranjan was just talking about history. The policy, it is estimated that 23 to 40% of hospitalized patients receive systemic antimicrobial agents at a given time, and about 40 to 50% of the use is inappropriate. We do not need to give more than 2 antibiotics IV or any other antibiotic after that. It has absolutely no use. The following principles for antibiotic use, and we have this antibiotic policy. If I have to digress from this policy, I have to report why I used a particular antibiotic. Review antimicrobial agents and select a basic formulary. Establish prophylactic, empirical, and therapeutic guidelines, and restrict use of agents to prevent antibiotic resistance, which is going to be a huge problem in the current scenario, the way antibiotic is being used. So the background to WHO facilitated country or area campaign, informal network, I don't want to take a lot of time, but this is what it is trying to say, that we cannot just use antibiotic irrationally in our patients. The antibiotic policy, empiric therapy has to be broadened, broad-based antibiotic enough to ensure most organisms. They say cefazolin was the best combination therapy of anti-pseudomonal penicillin, piperacillin plus an aminoglycoside, or anti-pseudomonal cephalosporin, ceftazidime plus an aminoglycoside have been for long the initial regime recommended officially. We must read this up-to-date article, and all residents and gynecologists must read this for basic knowledge on SSI. Surgical antibiotic prophylaxis to prevent surgical infection. There is a huge evidence, and I think we need to go and read this. As I said, 0 to 30 minutes is the maximum time that can elapse after the antibiotic is given. Single intravenous dose or a follow-up policy of removing it. The last dose given on the day the catheter has been removed. As then you can see in our antibiotic policy, in a hysterectomy, I'm only allowed to use cefuroxime and metrogyl. I've never used metrogyl in the last 10 years for any patient. I'm being very blunt and honest. And a maximum of 24 hours, as you can see here. If I have joint replacement therapy, plastic surgery, they write exactly what antibiotic we are supposed to use. ACOG recommendations for prophylaxis. Cefazolin perioperatively, cefuroxime is acceptable as an alternative because cefazolin is not available. For those women who have allergic to penicillin, you can use clindamycin and metrogyl. And for non-immune mediated hypersensitivity, you could use the cephalosporin again. For HSGs, I think this is extremely important. Doxycycline is the only antibiotic that they recommend for 5 days. Prophylactic antibiotic, procedure related, very, very important. Which antibiotic to be used in which procedure is being clearly mentioned. This is the form that I have to fill if I have to digress from using cefuroxime on my patients. It is important that I write to the OT nurse will come back to me if I ask for an antibiotic, which is not a routine antibiotic. CDC updates in prevention. Patients should have a full body shower bath with soap. Patients should receive antimicrobial prophylaxis before a cesarean delivery. Alcohol-based agents and skin preparation are appropriate. They know, mind you, plastic surgeons never use povidone iodine. They only use alcohol-based, chlorhexidine, alcohol. Plastic adhesive drapes are necessary for SSI. Do not administer additional microbiological doses. Do not put topical antimicrobiological agents like betadine on the wound after closure. And on for all patients, blood glucose level should be under 200 throughout the operation. Normothermia, I think this is very important. Patients should not be hypothermic, and patients should receive a higher fraction of inspired oxygen during surgery and after extubation for better perfusion. And blood products should not be withheld for SSI prevention. I think this is something that we need to remember. Use PPE whenever necessary. I think COVID has taught us that. Follow respiratory hygiene, cough etiquette principles, ensure appropriate patient placement, proper handling and proper clean and disinfect the patient care equipment. Handle textiles and laundry carefully, follow safe infection practices, ensure health workers' safety, including proper handling of needles and sharp objects. The antibiotic policy, ceftazidime and vancomycin. If vancomycin is not required, you could use a monotherapy. If a combination is needed, standard plus combination, you could use ceftazidime or you could use piperacillin. Here, of course, they've said imipenem, cefepime, or meropenem can be given to our patients if necessary. We need to all join this campaign to prevent antibiotic resistance, and we clinicians hold the control and have the solution. Emergence of antibiotic resistance. Most of them are susceptible bacteria, but if we use inappropriate antibiotic, we will have more resistant bacteria. Look at this picture that shows antimicrobial exposure. One of them, diagrammatic representation, is a resistant strain, but if we use inappropriate antibiotics, all of them will become resistant. So key prevention strategies: pathogen, infection, antimicrobial use, resistance, antimicrobial resistant pathogen. So that is why we need to prevent infection by taking appropriate measures. Effective diagnosis and treatment. Do not give antibiotics without culture. At the minute the culture reports come, step down your antibiotic if necessary, if the microbial agent has been identified. Optimize use only when necessary. Prevent transmission of antibiotics, of infection with proper care. Even the surgeon has a responsibility, and see that the susceptible pathogen does not become resistant. Prevent infection, diagnose it early, treat it effectively, adequately, use antimicrobials wisely, prevent transmission. 12 steps to prevent antimicrobial resistance. Vaccinate, and this is what COVID has taught us. Get your catheters out as soon as possible. Target the pathogen, assess the experts, practice a systematic antibiotic control policy, use local data for antibiotic sensitivity, treat infection, and not contamination. So often we see our urinary UTI, urine culture reports are contaminated with bacteria. I think we need to take a midstream sample. And the sample of a urine culture has to be checked within 30 minutes. If you give it to a collection center, it reaches the main lab in the evening. Know when to say no to vancomycin, stop treatment when cured, contain your contagion, isolate the pathogen. I think this is very, very important. If we don't treat antibiotics, the mortality rate from SSI is going to be 42%. And with appropriate therapy, it is going to come down to 17%. That's very, very important for us. Prevention is primary. Finally, friends, the aim of medicine is to prevent disease and prolong life. The ideal for medicine is to eliminate the need of a physician. Thank you very much for the patient hearing.
Thank you, Atul. It was a wonderful presentation you have done. Really, I went through all the cases which you have gone through, and once you stop learning, you start dying. That was a wonderful quote by Albert Einstein. And the grand finale was the last 12 steps, and these are very important. You have gone very nicely through all the aspects of different type of infections. I request Haresh Doshi sir to please give his expert comments.
Oh, thank you, Dr. Niranjan. Yes, Atul has nicely covered the all world statistics, guidelines, and points. And last 10 years, last decade, the whole world is speaking about appropriate and judicial use of antibiotic. And if you have to get your hospital accredited by NABH, they also, we had a visit last week in our hospital, and they're very strict about this, what policy you are you have implemented in your hospital regarding this antibiotic stewardship. I would say only two things, that two statements. Bugs are smarter than human beings. Always remember, bugs are smarter than human beings, and resistance runs faster than the research. With research, you come out with new antibiotics, but by that time, the all antibiotics are becoming, drugs are resistant for that microbacteria. The culture reports many times in the morbid patient comes as all R. You hardly find one or two S sensitive. So that scenario we never want to have it. And as you rightly mentioned, with patient to patient, you must have used your whatever sterilium or whatever clean. It is not after taking the full round. You must. Let me tell you, my residents are so casual now. The COVID is at least in Gujarat somewhat not seen near future. So third wave probably. They have again go to the wrong practice. They just take sterilium when they do want to PV in labor room, open the drum, sterilium wash and take the gloves and do the PV. And after PV, they will wash their hands. So it is bad. Before PV or before any intervention, you must wash your hands clean and safe, clean care. Thank you very much, Dr. Niranjan. Nicely covered exhaustive material and good points for SSI.
Atul, thank you so much. You have gone through all the aspects of nosocomial infection, healthcare associated infections, hospital acquired infections, and it is coming from a private practitioner. I can understand if this topic has been done by a medical college professor or a general hospital, but coming from a private practitioner, say, which is situated in an urban area with such type of infections. So what is the cause apart from whatever you have told? Is it because the doctor's aseptic precautions being not there, or the suture material which is not properly handed over to us, or the instruments which are not sterile, or we have the sister in charge which will label. There is an autoclave machine which is also labeled properly that it is absolutely fine. There are no germs or there are no organisms. We get reports from the microbiology department. We collect after the OT also the swab from the OT lamp. We collect it from the equipments. We also collect it from the sidewalls, etc., etc. And then we wait for 48 hours. So this is done every day. But those reports are usually negative most of the time, and that's why we operate. Otherwise, we would not operate. But how much ever care we take, Atul, I absolutely, astonished that in spite of the best hands, or is it because of the wrong suturing technique, or the gaps which are there, or it is too tight suturing? I mean, can you just throw some light on that also, please?
I don't think it is related to suturing. Yes, the respect to the tissue is extremely important. The way we suture, like I mentioned, that part at least 50% of times the patient's own body carries these organisms. So I think a perioperative bath is extremely important. Our personal hygiene, patient's immunity, body resistance, and of course, the kind of environment that you're dealing with. And I completely agree that there has to be a proper antiseptic cleaning of the OT, whether it's surface cleaning or deep cleaning, depending upon the surgery that has happened, no matter whether it is a private hospital or a government hospital or a corporate hospital. Because you may say that my incidence of infection is 5%, but for that particular patient, it is 100%. So I think care needs to be taken. You need to be periodically checking your side X-rays with side X strips. You need to be doing your routine swabs in the suction bottle, which is usually damp and moist if it is not kept open after surgery or while you are autoclaving. When the OT is being fumigated, if the suction bottle is shut, no amount of fumigation is going to reach the inside of the suction bottle. So I make it a point that the suction bottle is open when fumigation is going on. Routine swabs from the anesthesia trolley, from the OT lamp, from the surgical OT table. Periodic swabs from our own resident doctors. Periodic CBCs from our own staff members, our nurses. In fact, at Fortis, we even do nasal swabs of our consultants on a routine basis to see if this is carrying an infection. So I think these are some routine steps that we need to follow on a routine basis. If you do not find an infection, and if there is an infection which is a patient with an infection, I think photos are followed at all places. These are very important. Your nail beds, the way you scrub, the amount of time that you spend scrubbing. I think these are some important things. And the most common thing I said, after we wash our hands, we directly take the gown and we wipe our gown and dry our hands. I think these are some important, simple principles that we need to follow. After catheterization, we have been taught that we do not touch the Foley's catheter with our hands. We use an artery forceps to introduce the Foley's catheter. I have a video which I wish I could show. No part of the Foley's catheter is touched by my resident. I'm right there standing in front of them when a new resident joins, and I put the first catheter and I show it to her how the catheter has to be introduced. So
yes, sir. You have nicely covered all the topics, but can I speak?
Yes,
Sure,
sir.
sir.
Yes, sir.
In your lecture only, you mentioned that the prophylactic drug which you want to give should be in proper dosage and at proper time and proper selection. So that is very important. Otherwise, as you mentioned, patient factors, surgical factors, equipment related, suturement related, have a proportional. Some institute, something will be more, but all are responsible for SSI. All are responsible.
So you cannot use 1.5 grams of cefixime for 50 kg patient and 1.5 gram for a 100 kg patient also.
Yes.
It has to be a dose appropriate antibiotic.
Correct.
Per kg body weight. For example, paracetamol is to be used in a dose of 10 to 15 milligrams per kg body weight. So if you give crocin to a 100 kg patient, 500 milligrams of crocin, that fever is never going to come down. You have to use 1 gram paracetamol for that patient. I think even our basic OP guide teaches us that.
Yeah.
You have to give 10 to 15 milligrams of paracetamol to a patient.
Correct.
Every antibiotic that is used is dose specific. And we have to use the appropriate dose at the appropriate time. Very often it is seen that the antibiotic has been given at 6 a.m. in the morning in the ward and the patient comes to the OT at 8 o'clock. No point. My resident gets fired if antibiotic has been given in the ward. I would repeat the dose. There is no sense in giving the antibiotic either after the surgical incision or more than 30 minutes prior to the surgical incision.
Correct.
Absolutely. Now, Atul, you have showed a picture which is very, a big defect is there. It's red looking, and with all the technique which you have done. I mean, I'm not saying you. It is us, because as an obstetrician, we are accountable and we want to be very sure medico-legally. I tell my resident, it's not only you are taking a consent for all the surgeries which are taking, but pre-operatively how you will be doing. The patient will come to the OT. There are certain procedures. Intraoperatively what you will be doing, and post-operatively what can occur. So when you have explained all these things, but then when you see a patient who comes back to you in an OPD back with such a wound which has opened now actually it is a very difficult situation for a senior consultant. I'm sure a dressing will be done by a junior most person, or probably a registrar or a houseman, or at your level a clinical assistant. But such a situation is there. So I would request you, just lastly, how would you tackle this situation, and to explain the relatives, and so that, because they are really anxious, the whole tumor, say example, you have done a wonderful robotic surgery, or say there is a port site some infection, or you have done an open ovarian tumor removal, and at the end of the day everything is fine, she goes home, but now that one pus infection which is there, it still affects her a lot. So how would you go about it so that our younger members and the consultants can really make, get some cues from you?
The most important thing is when there is a problem or a complication, do not push your residents ahead. You have to have the guts and the gall to go and face that situation yourself. And at least the first couple of dressings and counseling is done by you in person. If you see a normal patient once a day, this patient should be seen 2 or 3 times a day if she's indoor. Except that there has been and tell them that we will try to the problem. It is not that it is the surgical this. Infection does occur sometimes. We will send the swabs, and the swabs will tell us why the infection has taken place. And you must tell them that we follow proper infection control measures. But international evidence says that infection happens. And that's when you need to face that situation, hear all the grievances from them, and do their periodic dressings and do an appropriate treatment. Of course, if it's a corporate hospital, you can downgrade the surgical charges. Be nice to them. Do not be rude. Do not tell them that it happened because your immunity is not good. I think you need to enumerate these. And this is a lecture I had made for my residents when I was talking to them when we have our residents. And that's why I said that I will speak about this, because sepsis is too large a topic. And maybe if Niranjan likes my lecture, sometimes will give me another opportunity to speak about septic shock and other ICU sepsis. So I think face the situation, accept, give clinical incidences and evidence to them that this can happen.
Yes, I think statistics.
Treat them empathically. Do not be rude with them, and manage that complication effectively. And do not push your residents to do the dressings and face the music. I think face that situation. The senior most person in the department should face that situation.
Very right.
Haresh sir, you would like to add? I mean, he has explained very nicely.
No, he has explained, and I follow this, sir. Being head of the department, 63 years old, I still do dressing once there is a wound gap or infection myself of the medical college hospital patients. That is a very important point he has raised. Otherwise, right, don't push the residents and be emphatic with the patient. That always we have to practice. But do dressing yourself, so you can have the right, whatever is happening, it is healing or not healing, worsening. So that is very important.
Amazing. I think that's what we have learned today. Dr. J B Sharma, who was there with us, a wonderful preview and a lecture by sir on SUI. A lot of points been discussed, and of course Atul sir has given a wonderful insight on surgical side with his experience and clinical scenarios, cases, and how to tackle with latest guidelines and statistics and the 12 steps. So I think it was wonderful. We have spent in the evening 2 hours leaving our consulting and our time with family members, and I value your important time to be given, Atul, in spite of your busy schedule, and of course Haresh Doshi sir, madam was there, and thank you so much on trending task. Now I request Dr. Prachi from Shield Connect to give vote of thanks.
Thank you, sir. Yes, I'm there. Thank you very much. Thank you, Dr. Doshi, sir, for being with us. Thank you very much for your support. Dr. Kar, sir, and Dr. Chandrawati, ma'am, thank you for being with us. Dr. J B Sharma, sir, has given amazing talk. And Dr. Ganatra, sir, for your continuous support. And yes, definitely we'll have one more session with sir again. Last but not the least, Dr. Chavan sir, thank you very much for your support, and without you, this is just not possible. So thank you again. Thank you very much. And again, thank you to all our audiences, our participants, for your patient listening. Thank you from Shield Healthcare.
Thank you. Thank you, Niranjan, for the opportunity. Thank you, Haresh bhai.
Thank you. Bye.
Thank you. Thank you.
Thank you, sir.
Thank you. Thank you. Thank you. Thank you.
Thank you, sir.
Thank you.